Thank you for that introduction, Chris. So as he said, I'll be presenting on deprescribing today, so more is not always better. So our objectives for today are to define polypharmacy as well as deprescribing, to justify medications for deprescribing by identification of appropriate indications, potential side effects, as well as goals of care, and then to identify barriers to deprescribing. And just as a heads up, there are some considerations specifically for the end of life with deprescribing in this presentation, but a lot of it does apply to a much larger patient population. Our first assessment question is what may predict clinical deterioration after discontinuation of cholinesterase inhibitors? A, greater than 4 comorbid conditions. B, pre-existing neuropsychiatric symptoms. C, younger age, such as less than 60 years old. Or D, male gender. Our second question is when can we begin to see diminished efficacy of benzodiazepines for insomnia treatment? A, 1 year. B, 24 weeks. C, 12 weeks. D, 4 weeks. Our third question is which of the following blood pressure medications should you consider tapering off of instead of abruptly discontinuing? A, losartan. B, clonidine. C, hydrochlorothiazide. Or D, lisinopril. Our last question is what does the A in the FRAME method for discussing deprescribing stand for? A, align with goals of care. B, aim to take over the conversation. C, agree to disagree. Or D, alter patient perception. And we will revisit these questions at the end of the presentation along with their answers. So what is polypharmacy? So depending on where you're reading the definition, it has been described as the use of multiple medications anywhere from over 5 different medications to over 9 different medications. And we do see that greater than 50% of adults between the ages of 57 to 84 years old take at least 5 medications daily. And we really do see a heightened negative effect of polypharmacy, specifically in the elderly patient population. So the elderly patient population are predisposed to risk from taking these multiple medications compared to our younger patient population due to different factors such as altered pharmacokinetics or dynamics, which would change the response to the drug due to different things such as hepatic dysfunction or kidney dysfunction. So we do see that polypharmacy is associated with increased ADRs, a negative impact on health, as well as disability. We can see increased rates of hospitalization and also increased risk of death. And the ultimate harm effects, such as unplanned hospitalizations, may vary with the number of comorbid conditions that a patient has. So specifically, those with a greater number of comorbidities were less likely to be negatively impacted by polypharmacy. And looking at the definition of deprescribing, I think most commonly it's described as identification and discontinuation of drugs where the harms, both potential and actual harms, outweigh the benefits of the drug. And this is really within the context of a specific patient's care goals, their current level of functioning, their life expectancy, and then patient preference as well. However, deprescribing can also be a reduction in a dose of a medication, as well as substituting therapy with a different medication that may be less risky to the patient. Ultimately, our goals with deprescribing are to really just reduce the potential harms to the patient. And this can include a wide variety of harms such as fall risk, oversedation, confusion, GI upset, myalgias, and bleed risk, which can all be very concerning to a patient as well as their loved ones. We also want to ensure the appropriateness of each medication. So looking at the specific indication for a specific medication, so matching medications to an indication. And then we also want to think about the prescribing cascade. Is a patient taking a certain medication to address the side effect of another medication? We also want to reduce the pill burden to the patient. That's important to consider. And then, as I mentioned earlier, really aligning the treatment with the goals of care. And deprescribing is not about denying patients effective treatment. Of course, if it's appropriate for that patient and we think that they would get benefit out of it, that's completely reasonable for them to keep on taking it. It's really about a patient-centered intervention where we're really making shared decision-making interventions with that patient, informing them of the potential harms versus benefits. And then we want to, of course, closely monitor the patient whenever we're discontinuing a drug to ensure that, they really are getting benefit from the discontinuation. So in our talk today, I will specifically review cholinesterase inhibitors, benzodiazepines, statins, inhalers, bisphosphonates, antihypertensive drugs, antiplatelets and anticoagulants, vitamins and supplements, and then antihyperglycemic drugs as well. To start off, let's talk about cholinesterase inhibitors. So this includes donepezil, rivastigmine, galantamine. It does not specifically, mention memantine, which is not a cholinesterase inhibitor, but a cognitive enhancing medication. But in a couple of the guidelines and recommendations that exist out there, they do kind of lump memantine into this group for consideration with deprescribing. Cholinesterase inhibitors, kind of looking at how they work, we see that in Alzheimer's disease, dementia, that there's a decreased level of acetylcholine in the brain. And the way that cholinesterase inhibitors work is that they inhibit the cholinesterase enzyme. And by doing this, we see increased levels of acetylcholine and then an increased duration of action as well within the brain. Specifically looking at the FDA-approved indications for the cholinesterase inhibitors, we see that they are approved for mild to moderate Alzheimer's disease dementia. So other types of dementia, such as Parkinson's dementia, Lewy body dementia, or vascular dementia, are off-label. So while some evidence does exist to support the off-label use, the evidence is weaker than its approved use, and the effects may be moderate at best or mildly associated with improvement in cognition or behaviors. There are some exceptions to this. So for example, donepezil is also approved for severe Alzheimer's disease dementia, and then rivastigmine is indicated for mild to moderate Parkinson's dementia, as well as severe Alzheimer's disease-related dementia. For more specific definitions on what is considered mild, moderate versus severe dementia, mild dementia is characterized by specific areas of functional dependence, such as trouble managing finances, for example. Whereas moderate dementia is characterized by multiple areas of dependence, such as being unable to drive or having difficulty with daily tasks, such as bathing and shopping. And then severe dementia is characterized by a total dependence, as well as motor and balance impairments. So what is the rationale behind discontinuation? Really, it's that there is a diminished effectiveness as dementia progresses. However, even though we see that the efficacy diminishes, we still retain the risks of potential adverse effects with these medications. Additionally, cholinesterase inhibitors are not associated with a slower cognitive decline, prolonged survival, or prevention of nursing home admission, which I think these are some of the reasons why both patients and their loved ones wish to continue these medications, even though these benefits are not proven with evidence. There are also multiple adverse effects that a patient can experience with these medications, including GI upset, which is probably the most common class of side effects that we see. So nausea, vomiting, diarrhea, abdominal pain. We can also see weight loss, dizziness and falling, headache, agitation, and insomnia, all of which can be concerning to a patient or troubling to them. And so discontinuation may help to resolve some of these issues if a patient is experiencing them. So some situations where we would want to consider discontinuation of this drug class is when, of course, the side effects become intolerable. If a patient is already non-adherent to their medication, so they're not reliably taking it anyways, they're likely not getting the full benefit of it. Of course, futile use, so if a patient is terminally ill. We also want to think about the rate of cognitive, functional, or behavioral decline, and when that decline is greater when the patient is on the medication versus prior to the initiation of the medication, that is definitely a signal to us that we can consider discontinuing it. And then when a patient progresses from moderate to severe dementia, we may also consider the discontinuation. And that is supported by different guidelines out there for cholinesterase inhibitors. However, with this drug class, we don't want to just abruptly discontinue the medications if possible. So really, ideally, we would do a slow taper, and this is to avoid withdrawal. So the withdrawal we can see somewhere between 3 to 7 days after discontinuation of the drugs, and the effects of the withdrawal can be anywhere from mild, such as insomnia or a labile mood, to severe, including hallucinations, delusions, altered consciousness, as well as agitation. Additionally, it has been noted that the presence of neuropsychiatric symptoms such as hallucinations and delusions at baseline could predict clinical deterioration upon withdrawal of this drug class. So the way we could approach discontinuation is to do more of a slow taper, such as decreasing the dose by 25 to 50% every 1 to 2 weeks. Of course, we're going to want to monitor for signs of withdrawal, and if there are distressing withdrawal symptoms, we can slow the taper even further. We could, of course, consider reinstituting at the lowest dose if that's appropriate. And then the use of anti-dopaminergic drugs can also be considered, but that's really more so for supportive care. So benzodiazepines and Z drugs, so our Z drugs being zolpidem, escloprazone, Zaloplan, are also considered drugs that are typically inappropriate in our older patient population and also towards the end of life in certain situations. So really the rationale for discontinuing these drugs would be an increased risk of falls, fractures, cognitive impairment, and delirium. We can also see other issues such as paradoxical reactions, additive, CNS depression, or risk for respiratory depression if a patient is taking other substances such as opioids or if they're using alcohol. We also see that the sensitivity to these drugs increases with age. We also may see that there is a diminished efficacy over time, specifically with use for insomnia. There's a lot of different drug-drug interactions to consider that can occur with this, both benzodiazepines and Z drugs. There's, of course, an abuse and dependency potential with these drugs that can be concerning. And then we also want to consider if we really have, an appropriate indication or if we're utilizing the drugs for the appropriate length of time. So this comes up a lot with insomnia. Patients who are on, let's say, a benzodiazepine for many years to treat insomnia, that may not be appropriate. And then we also see these drugs being utilized for nausea and vomiting, especially at the end of life, dyspnea, as well as analgesia. And so depending on the source of the nausea and vomiting or dyspnea, for example, the benzodiazepines may not be appropriate for their use. And really where they are appropriate is for anxiety that is causing, nausea or vomiting or dyspnea. And with analgesia, we really just don't see a lot of evidence behind their use for pain relief. Looking more into insomnia, just because I think this is commonly where these drugs are used in our elderly population, we may see that the efficacy can diminish as early as 4 weeks into treatment. However, like I mentioned earlier, it may be appropriate for use, near the end of life, specifically if the patient only has weeks to days left. And we also want to treat causes of insomnia if we can identify them, so treating the underlying cause. And this can range from restless leg syndrome, anxiety, nocturia, so the patient having to get up multiple times throughout the night to use the bathroom. And then poor sleep hygiene can, of course, contribute to insomnia. And there is evidence supporting that discontinuation has no long-term impact on quality of sleep versus continuation of those drugs. So it showed that those who tapered the benzodiazepines might have more sleeping problem than those who continue at first, but they saw that at 12 months there was no difference between the two different arms in the study for those who continued versus those who discontinued. So what does withdrawal of benzodiazepines look like? So we see that the symptoms can really have a range, anywhere from anxiety to irritability, which is pretty common. We can see sleep disturbance as well, tremor, nausea and vomiting, as well as seizure on the more severe end of that spectrum. However, seizures are unlikely to occur unless the patient was on, let's say, a really high dose of the benzodiazepine and it was discontinued without a taper, or if the patient has an underlying seizure disorder. And the duration of the withdrawal can be pretty variable as well, ranging from anywhere from a few days to as long as 4 weeks. And we don't see that switching to a long-acting benzodiazepine before the taper provides any benefit to avoiding some of these withdrawal symptoms. The approach to discontinuation for the benzodiazepines and Z drugs should be a slow taper if possible. So some of the approaches that have been supported out there include a decrease of 25% every 2 weeks, and then moving on to an even slower taper, such as decreasing by 12.5% every 2 weeks once we're getting closer to the end of the taper. It has also been described to incorporate planned drug-free days towards the end of the taper. We want to maybe consider slowing the taper for those patients who have a history of prolonged use or who have significant psychological comorbidities such as high anxiety or depression. We definitely want to monitor for signs and symptoms of withdrawal, and of course be looking out for any realization of benefits at each step of the taper. Of course, we can institute non-pharmacological interventions, specifically encouraging the patient to utilize good sleep hygiene, and then we also can incorporate cognitive behavioral therapy if possible. So moving on to the statins. So of course, we have atorvastatin, rosuvastatin, pravastatin, but I think even outside of the statins, we want to consider some of our other cholesterol-lowering medications, such as niacin and our bile acid sequestrants. So really our reasoning behind potentially deprescribing these medications is that we really question the utility, specifically with the amount of evidence that we have out there with patients who are more elderly, such as those above the ages of 80 to 85. There's really a lack of evidence supporting their use. And then when we're looking at the trials for these medications, we see that the endpoints of the trials were followed throughout multiple years. So really thinking about the time to benefit to these medications. We also see that certain statins do have a higher risk for myalgias, so lovastatin, atorvastatin, and simvastatin, and this is due to the fact that they have a higher lipophilicity, so they are higher risk for myalgias. And it has been described that approximately, not just with lovastatin, atorvastatin, simvastatin, but with the entire drug class, that 7 to 29% of patients do experience myalgias. What we have seen, though, in some literature is that discontinuation has been associated with a significant improvement in quality of life. And it wasn't associated with an increase in 60-day mortality. And it was associated with a cost savings as well. So in this specific study, the cost savings was approximately $700 over the course of about 200 days. This was looking at specifically patients who had a life expectancy of anywhere between 1 month to 12 months. And so that is additional considerations for their discontinuation. With our inhalers, there's really just a lot of barriers to appropriate use with this medication class. we have to consider a patient's inspiratory capacity. So thinking about our patient, for example, who might be end stage COPD, they're already on 6 liters of oxygen at rest. Do they really even have the ability to appropriately inhale these medications, or would they benefit obviously from just being changed over to a nebulizer? There are also dexterity concerns with some of these inhalers. So thinking about our patients who might have arthritis, for example, they might have a harder time manipulating the inhalers on their own. We also have to think about the ability for the patient to utilize the proper technique. So it has been shown that the risk of improper technique is associated with an increased number of inhalers as well as severity of airflow limitation. And then, of course, there are some adverse effects. Thinking specifically about our steroid inhalers, we can see thrush occur, especially if the patient isn't utilizing proper techniques such as rinsing out their mouth afterwards. And then, if we do discontinue inhalers in our patients, we of course do have alternative treatments. So thinking about some of our pharmacological options, especially for patients who might be closer to the end of life, we have nebulizers such as Duoneb or just plain albuterol. We have oral corticosteroids. Morphine, of course, can help with dyspnea. And then benzodiazepines, especially if the shortness of breath is associated with anxiety. We also have non-pharmacological agents, options such as nebulized saline, which is really just going to provide some moisture into the airways. Some patients do find benefit from fans blowing in their face, or just even opening a window to get a breeze into a room. And then, of course, oxygen. For antihypertensives, really the rationale behind discontinuing this drug class is that there isn't really a benefit of tight blood pressure control in patients who have limited life expectancy. And we also see that high blood pressure, or at least high blood pressure according to the guidelines, is often asymptomatic. There are lots of potential side effects as well as drug-drug interaction potentials to consider. And of course, they can contribute to pill burden to patients. And then we do see that the risk of hypotension is greater at the end of life as well, which can be detrimental to a patient. However, they still may offer palliation for certain conditions such as congestive heart failure, coronary artery disease, for example, with angina. We can also see them beneficial for patients who are experiencing edema, or if a patient has a history of a very high blood pressure or especially symptomatic blood pressure. Some other considerations with this drug class is that abrupt discontinuation is typically well tolerated. So it has been described that a patient may have headaches, palpitations, edema, or just a general feeling of feeling unwell. However, we do have medications that may be higher risk for not being tolerated very well if we abruptly discontinue them, such as high-dose clonidine, where we may see rebound hypertension, beta blockers, where we may see rebound tachycardia, or if a patient is on a combination medication, especially at higher doses. So with some of these higher risk medications, or even if we're just wanting to take a more conservative approach to discontinuation, it has been shown that we can do more of a quick taper over the course of 7 to 10 days in order to address this. However, there is some evidence out there that some patients do remain normotensive upon discontinuation of their blood pressure medications. So one study I was looking at showed that approximately 40% of patients remain normotensive after discontinuation of their blood pressure medications at 6 to 12 months. And then moving that out to looking at 2 years after discontinuation, they saw that 25% of patients remain normotensive. So it's definitely reasonable, especially if a patient has been very well controlled on their blood pressure medication, maybe especially if they're only taking, let's say, one blood pressure medication, to consider a trial of discontinuation in order to reduce pill burden, especially if the patient is interested in something like that. For our antiplatelets, the rationale behind discontinuation for this drug class, one of the big ones is an increased risk of serious bleeding, especially as a patient ages or if they are a higher fall risk, or even thinking about some drug-drug interactions that exist out there that can increase their risk of bleeding, such as patients who are on steroids or NSAIDs. We also want to think about the indication for the antiplatelets. For example, some different indications out there include dual antiplatelet therapy for patients who have gotten a stent or who have undergone a CABG. There's also dual antiplatelet therapy for secondary stroke prevention. And then we also see antiplatelets used for primary prevention, such as with aspirin. And I'll go into each of these specific indications in a little bit more depth on the next slide. And then there's also the cost consideration with this drug class, specifically for clopidogrel, ticagrelor, et cetera. They can be very expensive to patients, especially if a patient doesn't have insurance. So looking at the specific indications for our antiplatelets, starting off with our dual antiplatelet therapy for after a stent or after a CABG, we see that for stents, it really depends on whether it was elective versus whether the stent was placed after acute coronary syndrome, as well as whether the stent is a bare metal stent or a drug-eluting stent. So looking at our elective stent placement for a bare metal stent, it's really recommended to do dual antiplatelet therapy for at least 1 month after placement. For elective drug-eluting stents, we see that the recommendation is for at least 6 months after placement. And then post-ACS, for both bare metal as well as drug-eluting stents, the recommendation is for at least 12 months after placement. And then with CABG, it also depends on whether or not, it's elective versus post-ACS. So although both of them say at least 12 months after CABG, really with the elective CABG, it's a weaker recommendation. And with all of these, it is a weaker recommendation to continue beyond these timeframes, with the guidelines specifically saying it may be reasonable to continue. However, we often see patients remaining on dual antiplatelet therapy for years, including towards the end of life, regardless of these recommendations. For dual antiplatelet therapy for secondary stroke prevention, there's a couple of different recommendations out there in the guidelines. So for example, for patients who have had a recent, so specifically within 30 days, had a stroke due to severe intracranial artery stenosis, it does support the addition of clopidogrel, specifically though for 90 days afterwards in combination with aspirin. We also see that there is a recommendation supporting the addition of clopidogrel for 21 days for patients who have had a minor ischemic stroke or TIA within 24 hours of that event. And the reason why specifically with that recommendation for adding clopidogrel for only 21 days after a minor ischemic stroke or TIA is because the study that was looking at this did not find an additional benefit for stroke risk reduction after the 21-day period. And then finally, for aspirin for primary prevention, I think there's been a lot of literature coming out recently looking at the real, is there really a benefit for patients who are just taking aspirin, let's say for heart health? I feel like I see that often as a reason why a patient reports taking aspirin, even though they haven't had an event or any true indication to take it. They're really just using it for primary prevention. So looking at the ESPRI trial, which recently came out, I believe in 2018, they did show that there was associated with primary prevention aspirin use was associated with a 38% increased risk of bleeding, specifically non-fatal bleeding. However, they did not find any benefit for cardiovascular disease or event prevention, no benefit on disability-free survival, and then no benefit on mortality. And really actually what they saw in the study was that there was an increased risk of mortality in the group that took aspirin. Specifically, it was due to an increased rate of cancer in that group. However, the authors do mention to interpret that with caution because it was a pretty unexpected finding, so they're not exactly sure if that's truly associated with aspirin or not. And then for our anticoagulants, similar to our antiplatelets, We worry about the increased risk of serious bleeding. We also want to think about whether or not the anticoagulants are being used for, preventative use versus palliative. So with patients who have atrial fibrillation, for example, if you really think about the annual stroke risk for that patient, let's say, they have an annual stroke risk of 8% according to their CHA2DS2-VASc score. If you extrapolate that to a day-to-day risk profile, it's actually, of course, much lower than that. And so that may be something good to explain to patients if we're considering taking them off anticoagulation for AFib. We also want to think about their indication and recommended length of therapy. So the length of therapy really is going to vary depending on, for example, if a patient has a provoked VTE versus an unprovoked VTE. It's also going to depend on their risk of bleeding. So if a patient is low risk for bleeding or high risk for bleeding. And then for patients who have AFib, looking at their CHA2DS2-VASc score. So 0, of course, means that, you don't have to give them any kind of antiplatelet or no anticoagulation is recommended. If they have a score of 1, you can choose between either plain aspirin or you can consider anticoagulation for them as well. Unless, of course, they're female, then if that's, if they have a CHA2DS2-VASc score of 1 and the only reason they scored a 1 is because they're female, then it's not really recommended to put them on anticoagulation therapy. We also want to think about comorbid disease state limitations. So for example, a lot of these clinical trials that eventually led to the approval of the DOACs, for example, they excluded patients who had a creatinine clearance of less than 25 ml per minute. If a patient does have significant, renal disease, they may not even be a good candidate for the specific anticoagulant that they're on. And then, of course, cost comes into play as well, especially with our DOACs and even our, enoxaparin. Warfarin is a cheaper option, but it comes with a whole host of considerations and limitations to use, especially drug-drug interactions, the need to check INRs frequently, and dietary considerations as well. So even though we can consider, discontinuation of anticoagulants, they of course can be appropriate in select patients, especially at the end of life. If we have a patient who has had a recent VTE, then it would be appropriate to continue, especially if that VTE is symptomatic. So let's say a patient has a pulmonary embolism and they have chest pain, dyspnea, that's related to that, or if they have a DVT and have extremity pain related to that, then we of course would want to treat them with an anticoagulant if appropriate, so that we can hopefully reduce some of those symptoms. And if we are stopping an anticoagulant, there are some other considerations to think about. So let's say a patient or their family member is very against stopping their anticoagulation therapy. They're scared of the risks of stopping. We may want to think about if it would be appropriate to institute, let's say, a low dose daily aspirin instead of their, full on strong anticoagulant medication, so that the patient, may still feel good about having some kind of blood thinning medication agent that they're using, but not as strong per se as their anticoagulant, or it doesn't carry as many risks. We can also utilize different risk scoring tools, such as the HAS-Bled risk tool. So this is looking at a patient-specific risk of bleeding, and what it's scoring on is specifically hypertension, abnormal kidney or liver function, labile INR, if they're elderly, so specifically above the age of 65, looking at drug-drug interactions, such as the use of antiplatelets or NSAIDs, and then if the patient is using alcohol as well. So moving on to our anti-hyperglycemics, really some considerations for discontinuation is if a patient has a decreased appetite, which becomes more common towards the end of life. We're of course always concerned about the burden to the patient and their overall comfort, so thinking about pill burden, injections if a patient is on a GLP-1 agonist or on insulin, thinking about the blood glucose testing that goes along with that as well. We can definitely see limitations to use due to comorbid diseases such as CKD or hepatic dysfunction. And then we also want to think about the goals of care. So ultimately, especially at the end of life, we're really worried about the patient's comfort over these different micro or macrovascular complication prevention. And we really see that tight glycemic control only benefits patients who have a prognosis of years. So as the patient nears the end of life, our treatment goals, of course, change, and we're really just wanting to avoid symptomatic hypo or hyperglycemia and minimize the ultimate burden of their diabetes treatment. So if we're looking specifically at the different medications that a patient is using and which ones might be higher risk for hypoglycemia, we do, of course, see that insulin is higher risk for hypoglycemia, as well as the sulfonylureas, specifically glimepiride and glyburide. And this is because they have a longer duration of action or half-life compared to glipizide. And so while, if a patient was on glipizide, I would probably still recommend discontinuing it, especially at the end of life, if that's appropriate. It is lower risk than these other two agents. So with looking at the different adverse effects as well of these anti-hyperglycemic agents, some of the more common ones we see are GI upset, including nausea, vomiting, and diarrhea, urinary tract infections, and headaches. I think it's also important to counsel patients or educate them and or their loved ones on the signs of, for example, hypoglycemia if they're going to continue on these medications. So looking at sleepiness, sweating, lack of coordination or confusion, irritability, and hunger are some of the more common ones that they can kind of keep an eye out for. There are situations when we would want to continue anti-hyperglycemics towards the end of life. And so this really includes symptomatic hyperglycemia, so patients who are experiencing polyuria, polydipsia, confusion, patients who are higher functional status, or if they have an adequate appetite, that could certainly be reasonable to continue under close monitoring. And then patients who have type 1 diabetes. So these patients aren't producing any insulin, so they are higher risk for experiencing adverse effects of discontinuing all of their anti-hyperglycemic medications. And we really see that DKA, so DKA happens more commonly in type 1 diabetes, and this can happen very rapidly, so really just over the course of a day. And so unless the patient, we think they're very, very close to the end of life, it typically is appropriate to continue their diabetes medications if they have type 1 diabetes. And if we are going to continue, we can think about loosening their glycemic goals. So perhaps a blood glucose of anywhere between less than 180 to less than 360 would be appropriate as long as the patient isn't symptomatic at these numbers. We, of course, want to utilize any relevant medical history. So if we know that the patient has a history of HHS or DKA, and kind of where that occurs for them as far as what their blood sugars look like, utilizing that to guide our glycemic goals. And then we may increasingly loosen these goals as the patient nears the end of life. So we may become less strict with these goals as they progress from months to weeks to days left in their life. And ultimately, if we are going to continue, we can still consider minimizing blood glucose testing. However, for certain patients, they may have a lot of anxiety around stopping blood glucose testing. So of course, if the patient has a lot of anxiety around this and would rather continue to test their blood sugars, if that would be more burdensome to them to stop testing rather than continue testing, then we want to go ahead and let them do that if possible. It's really about thinking what the patient's wishes and preferences are as well. So bisphosphonates, I think, are another drug class that we can target for discontinuation in a lot of patient populations. And the rationale behind this is that, there are a lot of considerations for oral administration that can prevent their appropriate use, especially in patients who have limited life expectancy. So for example, with this drug class, we want to administer it on an empty stomach 30 minutes before foods. The patient isn't supposed to lie down for at least 30 minutes afterwards. And some of them, depending on what formulation you have, you can't crush it or chew it or break it. And this can be difficult for patients, especially at the end of life, who may not be able to sit up, for example. These medications also have a long half-life, so at least 10 years, if not longer. And we may see that the benefits are retained well after discontinuation. And in some of the guidelines out there for their use, it is supported that patients can even take a drug holiday from these medications after about 3 to 5 years of treatment. We also see that there are multiple side effects that can happen with these drugs, including GI upsets such as nausea, vomiting, diarrhea, abdominal pain, and GERD that can be bothersome to the patient. It can also be associated with musculoskeletal pain. However, we do see that these medications can be used in the palliative setting for bone pain. With our vitamins and supplements, I just wanted to give you guys some background on how widespread the use is of vitamins and supplements. So it has been noted, depending on where you're reading it, that 70% of older adults take at least one dietary supplement. 29% of older adults take greater than 4 dietary supplements, and less than 1/4 of patients who do take dietary supplements take it at the direction of a healthcare provider. And so some recent trends that have been noted out there in the United States, we see that there is an increased use by patients who are older than 65. We see a decreased use of multivitamins, garlic, ginseng, and PABA. And then we see an increased use of vitamin D, fish oil, coenzyme Q10, and cranberry. So really, there's no clear evidence of the benefit of vitamins and supplements for the most part, even though they are widely used by the US population. So it hasn't been proven clearly that they have any beneficial effect for heart disease, for cancer, cognition, or mortality. And there are potential harms associated with these medications, especially at higher doses, specifically beta-carotene, vitamin E, and vitamin A. Have been associated with potential harm, including increased mortality and then lung cancer risks with vitamin E, specifically in smokers. Although these vitamins and supplements may be considered cheap, depending on which ones you're getting or where you're purchasing them from, especially if a patient is on, let's say, 4, 5, 6 different vitamins and supplements, these costs to the patients can really add up. And then, of course, they do contribute to pill burden. So some considerations for deprescribing to kind of wrap up here, and I really think this applies to all medications, is we want to, of course, look at the indication, the risk versus benefit profile, which may change over time, especially as a patient is aging. We want to think about the time to benefit, any warnings or contraindications to their use, thinking about if the patient is even adherent to their medication, the prescribing cascade as well, the cost to the patient as well as society or the healthcare system as a whole, and then always thinking about a patient's preferences and values as well. So even though we have, I would say some pretty great evidence for rationale behind deprescribing some of these drug classes, there are, of course, barriers that we encounter, including uncertainty of benefit versus harm. And this uncertainty can be both from the healthcare provider as well as patients, fear of withdrawal or clinical worsening after discontinuation, uncertainty over how to discontinue their medication. There is the pressure to continue their medications as well. And this comes from both, again, patients and healthcare providers. The pressure to implement guideline recommended therapies, even though some of the evidence for those recommendations may not include, the patient population may not apply to that specific patient, especially when thinking about some of our more elderly patients. And then, of course, there's limited consultation time, right? So sometimes we only have 15, 20, 30 minutes to spend with a patient, and it may be hard to fit in time to talk about deprescribing. So how do we even approach this conversation, or maybe overcome some of these barriers that I just mentioned? So it has been described, looking at this came from a FAST fact from the Palliative Care Network of Wisconsin. They describe a FRAME method. So the F stands for fortifying trust, or really establishing that trust between, the provider and the patient. If we are insensitive about the way we approach this conversation, then that can lead to feelings of mistrust, or feelings of abandonment, like we just don't care about the patient and their health anymore. So we really have to establish that trusting relationship first before we can really start, I think, making significant progress sometimes with these deprescribing conversations. We also have to recognize patient willingness or barriers to deprescribing. So listening to the patient and acknowledging their concerns. So even though sometimes, we're worried about patients maybe being emotionally attached to their medications, it has been found that many patients are willing to discontinue at least one of their medications. And the way we may be able to overcome some of these barriers are to incorporate some open-ended questions into our deprescribing conversation, or to utilize motivational interviewing, for example. We also want to align deprescribing with goals of care. So I think this is especially important at the end of life, but it applies to all patients. We also want to manage cognitive dissonance. And so cognitive dissonance occurs when a patient is experiencing confusion from two or more contradictory beliefs or ideas, or really from what we're telling them about deprescribing their medications. So, they've been told their whole life that they need this medication in order to improve their health or to avoid having a heart attack or a stroke in the future. And so it can be very confusing and distressing to them when we're asking them to discontinue some of these medications. And so there's different techniques we can utilize to address some of these concerns. And I think one of potentially the best ways is by making it personal. So let's say you have a patient who they identify that something that is important to them is spending more time with their grandchildren, or being able to play with their grandchildren. And let's say they're on a beta blocker like metoprolol, and that they've been having pretty low heart rates, let's say in the 50s. And so we can talk to them about potentially discontinuing their metoprolol and how it may be contributing to their fatigue, which would potentially make it harder for them to, keep up with their grandchildren. So really making that personal connection. And then, of course, we want to empower patients and caregivers to continue the conversation. So really, deprescribing conversations shouldn't be limited to just one point in time. Sometimes it's going to take subsequent visits and conversations, really revisiting it over the course of, weeks or months, or sometimes even years, if need be, in order to, decrease their pill burden effectively. Lastly, I just wanted to leave you guys with some different deprescribing tools that exist out there. So we have Stop Frail, which I think is one of the more common ones. There's also MedStopper, which is an online tool where you can kind of plug in different medications. There's Less Cron, which is a list of medications and conditions for where we can consider deprescribing. And then it also provides monitoring and then follow-up guidance. There's PATH, which stands for Palliative and Therapeutic Harmonization. So this is looking at recommendations for deprescribing in the frail. So they provide recommendations for diabetes, hypertension, statin, and depression. And then there's also deprescribing.org, which I think is a very helpful website when considering deprescribing in a patient. So they provide different guidelines for deprescribing, different deprescribing algorithms. They have patient pamphlets as well, which can be really beneficial, especially if you want to provide a patient with some take-home reading if they're not quite sure if they really want to go ahead with deprescribing one of their meds. And then they have multiple other resources as well. And then finally, I included Thompson and colleagues. So they have a pretty comprehensive review of 15 different deprescribing tools, specifically for the frail or patients who have a limited life expectancy. Getting back to our assessment questions, our first one was what may predict clinical deterioration after discontinuation of cholinesterase inhibitors? A, greater than 4 comorbid conditions. B, pre-existing neuropsychiatric symptoms. C, younger age, such as less than 60 years old. Or D, male gender. The correct answer is B, pre-existing neuropsychiatric symptoms, such as hallucinations, may predict clinical deterioration after withdrawing these medications in patients. The other listed answers, such as 4 comorbid conditions, younger age, or male gender, have not been associated with increased risk of clinical deterioration. Our second question was, when can we begin to see diminished efficacy of benzodiazepines for insomnia? A, 1 year. B, 24 weeks. C, 12 weeks. Or D, 4 weeks. The correct answer is D, 4 weeks. Is when we can begin to see the efficacy of benzodiazepines for insomnia treatment begin to diminish, which is why it's so important to continually reassess if these medications are appropriate. Our third question is, which of the following blood pressure medications should you consider tapering off of instead of abruptly discontinuing? A, losartan. B, clonidine. C, hydrochlorothiazide. Or D, lisinopril. The correct answer is B, clonidine. This is because clonidine is associated with rebound hypertension upon abrupt discontinuation. The other medications, such as losartan, hydrochlorothiazide, and lisinopril, are not associated with rebound hypertension upon discontinuation or rebound tachycardia. So they may be better tolerated when abruptly discontinued. Our last question was, what does the A in the frame method for discussing deprescribing stand for? A, align with goals of care. B, aim to take over the conversation. C, agree to disagree. D, alter patient perception. The correct answer is A, align with goals of care. By aligning deprescribing initiatives with a patient's care goals, such as improving their fatigue so that they can interact more with their loved ones, we are more likely to get patient buy-in. We never want to dominate a conversation, but instead utilize shared decision-making. And while a patient may not be ready to discontinue a medication at one visit, successful deprescribing often takes place over the course of multiple visits and discussions.